Okay. History is really, really important for many cancers, and Susan did a beautiful job of this, talking about sort of the evolution of chromosomal development and figuring out how to test them, and the Philadelphia chromosome and CML. And similarly, CLL has a long tradition, and it really has been a remarkable time. I can't specify. I've been doing clinical trials in CLL for 12 years. And I can't tell you from running some of the original chemoimmunotherapies with sequential FCR and others and PCR, then coming into the era of the monoclonal antibodies and now all these new novel oral agents. It's incredible. It really is incredible. And we really have made strides in this disease. And it's going so quickly that it's hard to keep up because there are studies opening and closing all the time and at very fast pace. So stay tuned. So it's really, really a lot of advances. And what's old is new again. You saw data yesterday on chlorambucil and obinutuzumab. In the US, we don't tend to use a lot of chlorambucil. We just don't. But in Europe, in the UK, there was a lot of historic data that there was a great survival advantage with chlorambucil versus fludarabine. And so hence, you have an oral, cheap agent still in the mix. And that's why the FDA always, asks us to randomize, as silly as many of us think, randomize data against chlorambucil to get drugs approved. But there was a lot of good reason for that because chlorambucil has less toxicity and there wasn't necessarily a survival advantage in older patients when compared to fludarabine alone. So this is why some of those older therapies are still being utilized for the treatment of CLL. And clearly when you add an antibody, who knew? Look at the surprising results. We would have never expected that adding chlorambucil to obinutuzumab, you would have a CR frequency that you guys saw yesterday in 20%. That's a lot. Chlorambucil, less than 5% of patients with chlorambucil alone go into a complete remission. So having such a bump was really quite startling. Okay. So many of you know about the different treatment options, and so I'm not going to talk about them because you heard a lot of data about this yesterday. But I think it's important to know that until we have a cure for CLL, individualizing treatment, which we talked about in terms of your SEER score, your comorbidities, what we think you can handle, what are the goals of treatment, what may be some of these prognostic markers factoring in, that we still need to individualize treatment. And I understand that obviously for many of you who are Canadians, clearly getting some of these drugs approved is also a big hurdle. So there's a lot of things that come into play. Finances, your ability to get certain drugs. Part of this is approval as well. And also part of this is patient choice. So you have to, with your physicians, individualize and talk about therapies, side effects of therapies, and really make individual choices. Okay, I'll give you an example. I had a patient of mine who needed therapy, and they're young and fit. And we talked about FCR, and we talked about BR, and we talked about the kinases and a clinical trial because I obviously run clinical trials. And she said, I don't want a pill. Despite this fancy data, I can't take a pill. I can't take a pill indefinitely. I want 6 months of chemotherapy. I want to be done. I want you to monitor me after that because there's no way I'm going to be compliant. End of story. That was her choice. So these are individual choices until we find something that's curative. Remember, we want the therapies to be tolerable to you all, minimize toxicities, because if the therapy is worse than the disease, then we're not doing you any good. And you have to individualize your choices. So talk to your physicians. Okay. You guys saw all this fancy stuff. So obviously a very new era for CLL. Okay, so the kinases that we talked about yesterday and today, blocking certain proteins, really exciting stuff. And there's many more. But I want to show you this because I do want to show you for those of you who might be on one of these new oral agents, the reason why we think these drugs are so exciting is that traditionally when we talk about chemoimmunotherapy programs for CLL, if you got a cycle of FCR, bendamustine, and rituximab, remember you'd get that once a month. That's what a cycle is. It would take a month or two for people's lymph nodes to soften. You needed subsequent cycles to really make them vanish. But here, in a very short time, in a patient who was refractory, in a month, their lymph nodes are gone. So even in patients who had gotten a lot of chemotherapy, these are why these drugs really have made the excitement of CLL, paramount with all these new agents, because the response rates are very, very quick, very different than most chemoimmunotherapy programs. Okay, this is also a patient, but instead of ibrutinib, this is a patient on idelalisib, just to give an example of the dramatic change in lymph nodes. So what about clinical trials? Because obviously those of us who are here, the physicians who are here, are interested in advancing the care of CLL, right? We're all looking to make it better for you all and to find cures. And so there's a gazillion million trials running right now. And I think, Michael and both Michaels touched upon this a little bit yesterday, but it's really, really important that there's a lot of questions we want answered going forward to make it better for you all and to change the sort of traditional approaches that we've done in the past. And so there's a lot of trials looking at combining these agents with antibodies, even chemotherapy. I know that everybody's like, wow, why are we going back to chemo? It's still there because of that data that Michael had shown about FCR, and perhaps 20% of those patients in long term may be cured. Those are the patients who are mutated with a 13q, but there might be a subgroup. So are we throwing at chemoimmunotherapy just yet? Not just yet. We have to be conservative, I think. We'd like to get rid of it because some of the toxicities, but we still have to respect the data. So I think that you'll see that there's going to be a lot of clinical trials looking at combining. Can we maybe get somebody to have a really good response to chemo, maybe with one of these new agents plus chemo, and then stop therapy? Then they don't have to be on one of these oral agents indefinitely. So there's lots of different strategies. I'm just going to show you 2 trials of many. These are intergroup studies. These are not mine. But just to give you an example, in younger folks, one of the trials is randomizing FCR to ibrutinib and rituximab. So again, they're trying to see, can a kinase and an antibody improve or be better than the standard of care, if those of you think FCR is standard of care, but can it be better than FCR? In the older folks, well, since we now said that data that Michael Halleck showed you yesterday about bendamustine being more tolerable in patients who are older, so the BR regimen has sort of replaced FCR in our older folks in the United States. A lot of the older folks are getting BR instead of FCR. They're randomizing BR versus ibrutinib and rituximab. They're trying to see, can we replace the older therapies with some of these newer agents? And this is just a very small example of all the clinical trials that are running. Okay, now let's talk about practical stuff, a few slides on practical stuff. So for traditional chemoimmunotherapy, when doctors talk to you about cycles, a cycle of chemotherapy like bendamustine rituximab or FCR or PCR or RCVP or any of these labels that you hear is a treatment once a month, more or less. That's what a cycle is. So for most traditional chemoimmunotherapy programs, you're getting 6 cycles of treatment. So you're done in 6 months. That's what they're talking about, okay? What might you need? So even though your treatment's only once a month, what does that mean for you? It's not just once a month. You're getting blood tests more frequently. The doctor needs to monitor you. We want to look to make sure your counts are okay, if you need any transfusions. If you're neutropenic, you might get that injection, Neulasta or filgrastim, to boost your neutrophil count. So you might be seeing the doctors more often than just the chemotherapy treatment dates, okay? So realize that when you're getting real chemotherapy or chemoimmunotherapy, you're going to be committed for 6 months, and rightfully so. You want to get through treatment safely. Your doctor needs to monitor you. It's really, really important, okay? It's always important. People have mentioned the immunity quite a bit. And it's always important to note that obviously your CLL puts you more at risk for infection, but certainly when you're on one of these chemoimmunotherapy programs, you're more at risk for infection. So if you get a cold or a fever, you need to call the doctor. If you're being treated and something you think you're getting signs or symptoms of an infection, they need to address those issues quickly. We don't want you getting admitted in the hospital for pneumonia or some other infection. We want to prevent it. So if we can and we think you need antibiotics, we're going to give them to you. Okay, so it's important to communicate with your doctor. What about other things on treatment? Nausea can happen, of course. For those of us who do a lot of this, we try to prevent nausea before it starts, so we give you lots of anti-nausea medicines, and part of nausea depends on the drugs. So not all chemotherapy drugs for CLL will give you nausea. Same with hair loss. Most chemotherapy programs for CLL, you don't lose your hair. Okay, so you have to talk about these specifically with your treating physician. Cognitive changes. How many people talk about chemo brain? It happens, exactly. It happens, right? And the more, even if you're handling chemotherapy great, towards the end, your blood counts can be beautiful and your lymph nodes can be gone, but you might feel foggy and tired, even though your hemoglobin could be normal. That's the cumulative nature of chemo. And I tell my folks who are getting traditional chemoimmunotherapy programs that it's going to take several months after their last treatment. Try like 3-4 months for them to kind of feel like they're back to themselves again. Okay, so there are changes that occur that while you're on a chemoimmunotherapy program. I think it's important that patients get prophylaxis for herpes and for pneumocystis. I believe it or not, even with the oral kinases, and this is something we can evaluate, I just had my first case of PCP on ibrutinib, so I prophylax. The person who got it was somebody who chose not to be prophylaxed. So there are simple things that we can protect you from rare and atypical infections that I think are important. And then the person who asked about dental, no elective procedures on chemoimmunotherapy unless it's an emergency. So if you are on chemotherapy, you're getting FCR, and you want to go for a cleaning, no. I tell my patients, absolutely not. If you have a dental emergency, like an abscess, okay, we're giving you antibiotics and you're going. But no elective procedures when you're on chemoimmunotherapy. Now, the pills are different. So for people on kinases, you're going to be on these agents long term. That's different. If you need a root canal, or need aggressive dental work, I prophylax. If the dentist doesn't do it, I do. But just cleanings, no. Okay, and then for those 1 or 2 slides left, for those of patients in the watch and wait program, I think everybody stressed this enough. The tempo of your disease periodic monitoring, your doctor's gonna tell you when they wanna see you. If they see a change, they might say, come back a month sooner than I normally see you. I just wanna see the tempo of what you're doing. Every doctor is different. It's individual, and what you're doing is individual. Recommendation, you guys heard plenty about vaccines and also not having live vaccines. And we talked plenty, Erin talked beautifully, as well as others, about taking care of your body. We can't stress that enough. If you take care of your organs, then depending upon the side effects of some of these agents, you'll better be able to handle them. So take care of what you can. And cancer screening, of course, Erin discussed in great length and beautifully. Stay up to date on your cancer screening. There's no limitations on your activity. If you're in the watch and wait crowd, do whatever you want. There's no restrictions. I mean, sometimes I'll ask my patients in front of their spouse, do you need me to write so you don't have to take out the trash or mow the lawn? Okay, I'll give you a doctor's pass for that. But other than that, really, there aren't limitations. You want to travel? Travel. Okay, sometimes I'll tell folks if they're going into areas that are where there may not be access to health care, sometimes I will offer antibiotics so they have a prescription they can take with them depending upon where they're going. Doesn't replace medical care or seeing a physician, but if I know that they need something, they have it with them. And always report infections to your physician. Some people work with their internist on that, others, their primary doctor. In my case, I usually have my patients tell me.